All right. So we pulled in the rest of the panel. I'm just going to introduce them real quick. Unfortunately, Tina Atkinson was going to be here and she had a women's hockey emergency pop up, so she's unable to join us for the panel. So Ven, you're currently still on the panel in the boardroom, but we can pop anyone in or out of that. Natasha Desai was born and raised in Southern California, earned her medical degree from the George Washington University School of Medicine, completed her ER residency at Mount Sinai, followed by a sports medicine fellowship at CHOP. She initially started her career with a hybrid position at Columbia University, where she was an attending in both the emergency department and in the orthopedics department. She was the team physician of Columbia University Athletics and then recently transitioned to full-time sports medicine, moved across the island to NYU Langone, where she is an assistant professor in sports medicine in the orthopedics department and serves as a director at the Center for Women's Sports Medicine at NYU, and she's also the head team physician of the Brooklyn Football Club women's team. Laura Anderson is originally from the Boston, Massachusetts area. She completed her master's in nutrition at Columbia University and medical degree at Albany Medical College, where she became a member of the AOA Honor Medical Society. She completed a residency in emergency medicine, followed by a sports medicine fellowship at Mount Sinai in New York. She's previously served as the chair of EMRA's Sports Medicine Committee. She now works in the Departments of Emergency Medicine and Orthopedic Surgery at Cambridge Health Alliance in Cambridge, Massachusetts, where she also covers football for a local high school. She enjoys spending time with her family, including her 3-year-old son and 1-year-old daughter, running with her puppy, hiking, and triathlons. She completed the Lake Placid Ironman during medical school and enjoys training for marathons and triathlons. Eric Friedman grew up in New York and graduated from Wake Forest University in Winston-Salem with an undergraduate degree in continued education at Wake Forest School of Medicine. After graduating with his MD, he completed his residency in emergency medicine at the University of Maryland. And after residency, did a sports medicine fellowship at Duke University Hospital. He served as team physician for Duke University, Elon University, and a team physician for a local high school football team. He now lives in Charleston, South Carolina, and is core faculty and director of sports medicine for the Trident Medical Center Emergency Medicine Residency Program. He also works at a private practice orthopedic office in Charleston Sports Medicine. And my goal for putting this panel together was try to get a wide range of different career choices, career paths, different stages in your career, and just to let you guys talk to everybody out there about what you do, how you got there, and advice you'd have for them, things that you've had to overcome getting where you are. Then I don't know if you want to start asking questions or Alex.
Yeah, I can start. I guess I'll open it up to the panel to start with a pretty broad question. And I guess I see Kori to my left here. So we'll start with Kori. How did you find out about a career in emergency medicine sports?
So I'll throw in here a little bit of the going back and do fellowship question. So I like Liz Della Silveira kind of went into medical school thinking I wanted to do sports medicine. So I was an athletic trainer. I loved sports medicine before I went to medical school. I thought that meant sports orthopedics. Got into medical school, realized I was not a surgeon. Really loved the emergency department because it has so much of that initial assessment evaluation, including of the orthopedic and sports injuries, still allowed some sideline care. So I went into EM. When I finished residency longer ago than I'd like to admit, sports medicine fellowships really may have been available for EM grads, but that certainly wasn't public knowledge. So I took a faculty position at Georgetown with our inaugural class of interns. Our very first class of interns came in my first year on faculty, and I was a faculty member for several years. And then it was when Liz came back out of her fellowship and we built the sports med fellowship at Georgetown MedStar that I asked the department if I could take a sabbatical and be the first fellow and kind of beta test the fellowship, kind of get my own board certification, and then came back to faculty. So I kind of always knew that sports medicine was where I wanted to be. I didn't know I could do it through emergency medicine. It has certainly afforded me a lot of opportunities. I joke and say that no 2 years of my career have been identical back to back. There's always been a little bit of change, whether it's a new role, a new title, a different percentage of emergency medicine versus sports medicine. I'm now currently doing the fellowship plus some other administrative things. I'm about 40% clinical outpatient sports medicine and really just work in the ER/PRN, which looks like 1 or 2 shifts a month.
Cool. Thank you, Kori. I'll go down the line. Laura, was this your plan entering residency to do sports medicine?
Thank you so much. I'm very excited to be here. And I would say that, going into emergency medicine residency, I was always very interested in doing a sports medicine fellowship just because of my own personal interest in sports. In medical school, like Ben said, I did an Ironman competition, just very interested in endurance athletes. But I think what really made me interested during residency was first rotating on orthopedic surgery during my intern year, and then also working with who's actually on this call, Dr. Amy Kim, who's here, who does emergency medicine and sports medicine at Sinai. So I think just I know it's already been talked about, but having amazing mentors, for me, that was super important. I was able to go to clinic with her and learn all about what she does, and also working with Ben also in the ER at Mount Sinai, Beth Israel. I think talking to as many people as you can and seeing what their paths are, that's been super influential to me and made me want to do fellowship.
Sweet, thank you. Jace, I feel like this one is perfectly timed for you. How late is too late to decide on the career path? Like, is there a too late to go back?
You're muted.
I think, Jace, you might be muted. Ben, can you unmute Jace by any chance?
There we go. Sorry. That's a good question for the program directors, because they're more the decision makers on that. But it's never too late to go back and do a fellowship and relearn and learn something new. When I finished my residency, I'm like, I'm done. I did a 4-year ER residency, and the whole 4th year I was angry that I wasn't practicing. Never going to go back to school again. Went back and got an MBA. Went to work for the National Basketball Association, decided I was undertrained to be able to do the job I was doing. The league didn't feel that way. I felt that way. So I actually went into a lockout year and did the fellowship. And, you're never too old to go back. The one thing with retraining, of course, is going from an attending life into a fellow life is a fairly big shift, both financially and also the best advice I heard from somebody is, if you're going to go back, even if you're 10 years in the pit, is be humble, right? You're not in the pit, you're in a fellowship. It's a totally new specialty with new rules and the whole 9 yards. And we have so much to learn. 1 year is not nearly enough time to learn non-operative orthopedics. It's a logical starting point to journeyman. So when you get back, be humble. But yeah, it's never too late to take a new direction.
Cool. Yeah, I agree with you. As a program director, my fellow last year was an ER doc for 20 years and came back to do a fellowship after 20 years last year. And the biggest thing was he was humble. He respected the role of the reverse, that he was no longer an attending, that he was a fellow, and he respected that role. And he really, really put his foot down and really did an amazing job. So yeah, I agree with you there, Jace.
Yeah.
Cool.
I'm going to ask, and then Jasmine has had a question also, but just especially the people up on the panel who are just in their first few years out, what did you do to look for a job? How did you find your job?
I can take this one. So I'm, I guess, 4 years out now. The advice I do 10 to 12 shifts a month in emergency medicine and just 1 day a week in outpatient sports. So the advice I got, which I think was good advice, was find the emergency job first, since that's what you're going to be spending most of your time in. So I did that. And then after I found that, I kind of basically asked around and I cold called offices and used some contacts at Duke to try to get my foot in the door somewhere, and ended up with this hybrid, which is what I have now. So a lot of just I called probably 6 different, cause I thought I knew I didn't really want to do full academic medicine, which is what probably a lot of people here do, is so that way they can pay you from the emergency department as well as the ortho department. So it made it a little bit harder, I think, for myself, but it ended up working out.
I can speak
Go
as
ahead,
well.
Laura.
Oh, sorry, no, go ahead.
Let's go.
I was just gonna say that again, like speaking to as many people as you can is so helpful. Like I spoke with Ben, Dr. Faden, who's on this call, figuring out what other people are doing and figuring out most importantly what you want to do. For me, I reached out, I did kind of a combination of things. Like at some places, I reached out to the orthopedic department or the physiatry department first, or at the same time as the emergency department. My current job that I ended up at, I just went through the emergency department first, and then they set me up with the chief of ortho, who was very excited to talk with me more about a position. So I think that, probably, for me, I reached out to both at the same time because I was really interested in doing a combined role. But I think, and honestly, it really depends on what you're looking for, because if you want to do more emergency medicine, then it probably makes sense to go through the ER first. If you want to do more sports, then it probably makes sense to look for a job in sports. Right now, I do 2 days a week of clinic, and then I do 4 to 6 shifts a month in the emergency department.
Thank you, Laura.
Something important, and you heard it in Natasha's bio too, right? Is that you don't have to find the perfect job right out. I think a lot of people kind of struggle thinking that they know exactly what balance they think they want, and they're looking for the job that gives them exactly that balance. I would argue you don't really know what you want until you start doing it. And then life comes at you, and that might be family, it might be kids, it might be geography, it might be ill parents. What you think you want is going to be different 5 years from now than it is right now. So just get into a job that where you like the people and where they're open to the idea that you can do this kind of split role, if split's what you're looking for. And then let the slider slide left and right? You're going to maneuver this over time. So find a place where they're open to the idea of letting you do this.
Amen.
The only thing I was going to add before is that when I was first applying, it was a lot of cold calling, and I've heard that kind of from everyone who mentioned it. I ultimately found a job through a posting through MSSM, but most of my interviews were just cold calling the ERs and suggesting that I wanted this hybrid role. And a lot of them were willing to work with me, especially, now it's been a number of years since I did that. This was a new kind of idea of this hybrid role and vice versa. So my initial role at Columbia, it was 100% sports role. And I wasn't ready to fully commit to sports. I was just coming out of fellowship. I was more an ER physician than I was a sports physician at that time. So I really pushed to get a hybrid role, and my ortho chair reached out to the ER chair and made it happen for me. So I think these roles still aren't as well defined for us. So there is a little bit of wiggle room. So if you're seeing a job posting or a position that kind of fits what you want, location wise, institution wise, don't be afraid to ask how to make it a little bit more tailored to you and in your specifications of EM versus sports and your distribution of that.
Can I make a comment on trying to get an ortho job?
Yes.
So that advice actually holds pretty well for trying to get a full-time sports job. This is me. I've never liked the term sports medicine. And the reason is it sounds very isolating in what we do. And what I personally prefer is interventional, non-surgical orthopedics. Although you can certainly do more than that. And when you're going to pitch, what you said was perfect, which is you cold call and you say, this is what I do and this is it. And we do something unique that other specialties don't do. We exhaust all the non-operative options. We have a wide variety that we can see. I'll see children. I'll see old people. I do casting, and that's unique. But you put your CV together, and then you go to the groups in the area, and you you present yourself. And a lot of times you'll find jobs on AMSSM, on the website or the national meeting, but you can also sort of pick the geography that you want to work in. And I know this sounds weird in ER, but also the patient population you like to work with. Because if you're working in one demographic versus another, you may get along with that demographic, but not that demographic. And so where I work, very affluent community, close to the water, Rolls Royces in my parking lot every day, that has its own issues. So very demanding, I want this now, etc. So when you go to find out a little bit about the group, and then get your CV together, call them on the phone and cold call them and explain what you do. Right now, non-operative orthopedics, sports medicine is hot. A lot of people are looking for it as sort of being able to expand. It's the hub and spoke. The hub is surgeons, the MRI, the outpatient surgery center. The spokes are the people that are out seeing everybody and moving them in. And you can be an integral part of that. But that's exactly the same way. Sometimes you just got to get on the phone.
Cool, thank you. On that same topic, once you get into a role, how do you have any tips or tricks of working with our orthopedic surgery colleagues?
Well, we know they're rabid cats, so they can be challenging to work with. I think the thing that ticks off most orthopods, and I actually give a lecture on this, and I have for a long time, and I'm not an academic, so I'm not going to offend Georgetown or anything. We don't know what we're doing, right? I mean, you'd never call a cardiologist and say, I don't know what the hell this EKG shows, but why don't you take over? And you'd never call a surgeon and say, touch the belly? What are you talking about? CT? Who would do that? But we do this with ortho all the time. I mean, we really don't know ortho. I mean, I'm talking about ER, not sports. I didn't know what I didn't know, and it was a shocking amount, right? So the ortho guys and women have a way that they want to be talked to. They have a language, just like we have a language, and the cardiologist has a language. Try, be competent. This is a recurrent message. Be good at what you do. Be a student of what you do. Exhaust all the non-operative options. Don't be afraid to ask for help. I saw a kid yesterday that's 10 with an incomplete patellar fracture. How often do you see that? I called the pediatric ortho guy. He was happy to help, right? And be a student of the specialty and the activity. The thing that keeps us from being killed by ortho is the cell phone camera, right? Because before that, these guys would be screaming at us all the time, but at least you can take a picture of the x-ray. But we should know how to do all that. And then when we do call, we're asking as a colleague and competently, and they appreciate it, right? So if you come from that direction, you're treated as a colleague. They're all ultra alphas, so you just have to act that way and everything's fine. And when you don't, and you annoy them, and you don't try to pull the wrist in for the colleagues because you're too lazy to put them in a finger trap, that, and they have to get up and do it, that makes them mad. And it would make us mad too.
So I'll jump there too. And I think it's important to know your practice area, right? So in both of my clinic days, I share a clinic with orthopedists, and there's value there because we can go back and forth. I mean, we're literally in the same space. So when I see a patient, an athlete who has a fresh ACL tear, I can walk down the hall and say, hey, I've got this patient with an ACL tear. Do you want to come meet her now? Right. And so the surgeon can come in, the patient gets 2 visits for the price of 1. They've met the surgeon. I'm endorsing the surgeon. The surgeon loves that I'm handing them a gift wrapped ACL surgery, right? I order the MRI. I order the PT for prehab. The patient's happy. Everybody's happy in that case, and we all move forwards. Likewise, I like treating runners, right? an orthopedic surgeon doesn't give a crap about treating medial tibial stress syndrome or the stress fractures and all the things that go with that. So they're very happy to introduce me to that patient and say, Dr. Hudson's going to take over your care. She's going to get you the workup and the DEXA scan and help you onward. So again, there's some symbiosis there. And I'm happy to kind of say every once in a while, they'll say, hey, do you have time to add on this ultrasound guided hip injection today? Because this patient's getting ready to go on vacation. They'd really love to have it now. Sure. Right. I do that now. That patient likes me. They know I do these things. They're going to just as likely to come back to me because we've just defined this as a non-operative orthopedic condition. And again, that's kind of the warm handoff, right? I'm helping the surgeon out to keep their patient happy. Their patient comes back and sees me. So again, it goes both directions, and that's how you form a great relationship. I mean, it's ice season for East Coast skiers, right? So this February is ACL month in my clinic, and I feel like the ACL fairy. It's like you get a surgery and you get a surgery and you get a surgery, and by Easter the surgeons are sending me cake. So this is how you form a good relationship with your friends.
Share.
I think I'm a big proponent, if you're going to have a sports practice, to have good orthopedic colleagues at your side and know who to contact for what problem, because as was mentioned earlier, I'm not sure who said it, but that 1 year of sports medicine, especially coming out of an emergency medicine residency, is just not enough to know everything. And it's vital to have those colleagues that you can lean on, and the resources you can lean on. I do think asking them questions and then being able to have a discussion about it, one, makes you grow, but also lets them know what you're capable of, because you're able to respond back. Oh yeah, if that's the case, then I can do this injection, or I can work with them in this way. And it introduces to them all the things that you're capable of. And definitely when you're trying to build your practice, and at all times really, for a good practice model, trying to get your surgical referrals in, because if they see that you're able to do that ultrasound guided procedure within a few days and communicate with them at a higher level, they're much more likely to send them to you than interventional radiology or things like that. So I definitely think that growing with the ortho surgeons, especially if you joined a practice at the same time other ortho surgeons are joining, you guys grow together, and it's been really vital to my practice so far.
Natasha, kind of to piggyback off of that, we talked about joining a practice with orthopedic surgeons. I know you transitioned athletic departments within the past few years, and maybe the other panelists can speak to this, but how do you ingratiate yourself within a new athletic department when you're transitioning into, maybe already an established situation?
So I'm not in an athletic department anymore. I switched universities altogether. So I used to be a team physician within the institution I was in. Now I'm at NYU, and I have my primary care sports practice. I'm no longer in the ER. We've developed a center for women's sports medicine, which we have some contracts, one of the most notable being the Brooklyn Football Club, which is a new professional women's soccer team. So, in terms of building that transition, the major thing that I look for, as Jace mentioned earlier, is I wanted to be in an orthopedic practice. I've personally found a lot of value in that. It's not always possible, depending on where you are. But I no longer practice sports medicine. So one of the things emergency medicine. So one of the things that was important to me, and that I'm still trying to keep my roots in, is that I am the one giving the emergency medicine based lectures to our fellowship, and in a big concussion conference we have coming up, I'm the one giving the emergency medicine perspective. So I'm trying to keep my emergency medicine roots that way within my 100% sports practice. I'm not sure if I answered your question, but hopefully I did.
No, that's great. And, obviously it's becoming a much more common career path for a lot of our emergency medicine residents that are on this call. And, as you explore fellowships, the fellowships offer a differing amount of emergency medicine exposure during fellowship. And, sometimes that first job out, you may not be able to get the ideal balance that you're looking for. So maybe for Eric and Laura, as they have recently come into practice, what would you say to somebody that maybe has to not practice emergency medicine for a year during fellowship if they're going to a primary care based fellowship and wants to come back and do some split time? How little is too little emergency medicine, early on in your career?
And I can go first. So I did ER attending shifts at Duke, but I mean, every shift I had a senior resident. So I was doing year. And then kind of coming back, I started really quick. I was only 1 year. I didn't feel like I lost that. But I could definitely see if I took multiple years off, but just the 1 year, and I was at Duke, like the Duke ER, so I was seeing high acuity patients. So I was still having the mental side of it. It was just the actual procedure side. I didn't do. I know I've talked to colleagues who have tried to moonlight during fellowship in an ER to just keep their skills up if they were, I know some programs do lower acuity or urgent cares or something like that. So that was kind of my experience.
I think this one depends a little bit. Oh, Laura, you go ahead.
No, go ahead.
I was gonna say, I think it depends, right? If you're coming straight from a 3-year residency, if you're coming straight from a 4-year residency, or if you've been out in practice for a while. I mean, every fellowship should have at least a half a day a week of continuity clinic, but we know that varies a little bit, right? Some places, if you do a primary care, like a family med program, that might be urgent care. It might be walk-in clinic, which meets the GME requirement, but is certainly not the same as working in a level 1 trauma center or a busy resuscitation bay. The last time we surveyed this, it looked like most of the EM-based programs were doing something similar, which is about 1 shift a week or about 36 hours a month in the ER. Those of you who know our program know that that's what we're doing. I'll say that if you're coming straight from residency, that's probably about the minimum you want to do. It I think is hard to cement your skills as an attending in the ER without doing at least that much or a little bit more. And I'll say that as somebody who came out of a residency program straight into being an attending and felt like 17 shifts a month was like still drinking from a fire hose. Like it was really still hard. Being a new attending is hard, right? And being a new attending in a busy ER is really hard, even if you were a chief resident in a busy ER. So not having a year's worth of experience, if you're going to jump into a really busy department, is going to be a little bit of a shell shock. So I would not do less than once a week if you haven't been out in practice for a bit.
I'm going to step in for a second and echo what Kori said. Our program does once a week, 12-hour shifts. And at that point, I feel like it might even be a little bit on the lower side. I went straight from fellowship back to the emergency department. And for sure, that first year is challenging. And especially with only doing, 48 hours of clinical a month, it's very challenging. So whatever you can do to keep up your skills, I'm going to back exactly what Kori said.
I'm also gonna agree with that. So during fellowship, I did 1 10-hour shift a week. It was the same shift every week on Fridays. And I think that any less than that, and I think I wouldn't have felt as comfortable as I do going into as comfortable as I did going into my first real attending role. And I started out doing about 8 or 9 shifts a month in my attending role with 2 clinic days a week. And then, after being in my role for a year, I actually reduced down my ED shifts a bit. So just also going back to, a lot of times the first job you have isn't exactly how, I'm still figuring it out, to be honest. And I think that it takes time to figure it out. But yeah, I did interview at fellowships, which were, there was no ER ED shift. It was urgent care was an option. And for me personally, it was really important to do my ED shifts.
Yeah, I'll echo that too. I did the same fellowship, the same shifts that Friedman did. at Duke. And one of the selling points for me was that you're working as an attending. Some fellowship programs you'll work as basically a glorified resident. You're still presenting, but sort of you're treated as an attending. It's kind of a gray area in between. And some of that has to do with just hospital policies and how they interpret laws and things like that as to whether or not you can actually be treated as an attending. But you're also, like Laura said, you work the same shift every week. I worked for a year. I worked Wednesdays 7 to 3. And you see different pathology Wednesday mornings than you see Friday night overnight, Saturday night overnight. And so, even doing that for a year, it was you still get that moment of shell shock when you start working. And when I started working, and I got my job a lot thanks to Natasha, actually. We worked together for a few years. But I was working 80% in the ED 1 day a week in sports clinic. And it made my head spin. I was like, oh wow, wait, I'm doing real ER again. And I felt like I'd worked enough to not totally lose my skills. But it definitely felt like I was kind of getting thrown back into the fire to some extent. And then there's a question in the Q&A right now, and maybe some other people can talk about this too, sort of the reverse of that. Advice on keeping up sports medicine skills while practicing only emergency medicine and looking for sports career opportunities, which I can speak to a little bit now because right now I'm full-time in the ED, except for some event work that I do through the MBA, which varies in how much sports medicine that is. But I will pull out the ultrasound a lot more than my colleagues. I will very occasionally do joint injections. I don't do a lot. I'll do maybe 1 or 2, 3 a year for very, very particular circumstances. If I'm trying to avoid admission or someone who's really not going to make it to follow up, but those kinds of things to try to keep up my skills when I'm not having a regular clinic day.
Yeah, I'll back what Ben said there because I'm 100% emergency medicine right now. I think if you can get somewhere into an academic niche situation where maybe you can teach some residents some sports medicine, because the more you teach, the more you'll be able to remember and recall, is great. Also, at the same time, if you can get hooked up with anything local, even at the high school setting, just doing some basic high school sports coverage, that's going to help you keep your skills as well.
I'll go by the opinion that there's a ton of ortho in ER. You just toss it to the PA usually. So if you actually go looking for it, there's a lot of ortho to do. Tons of fracture care, tons of shoulder, tons of knees. You just have to go after it. The deficit of so the difference between practicing sports full-time and ER is everything is unscheduled episodic in the ER. And the hard transition for me into, I kept doing ER for a long time until I finally said, okay, that's enough. But I was 17 years in the pit. And the transition was the longitudinal care part, right? Which is, okay, I see this knee, I see this meniscal tear. What do you do with this when you're not seeing them once and sending them somewhere else? So you can find the pathology in the ER. The work portion for us is be thinking like, okay, what would you do with this in a week and in 2 weeks and in 4 weeks and in 6 weeks? And what's the interventions? And that's the self-education thing, because the vast majority in ortho clinic is longitudinal care, which we don't do at all. So if you can concentrate on that, look for the ortho stuff. It's out there. Every ankle, there's a thing that said there's no such thing as a simple ankle sprain. That is so true, right? There's so many variabilities to ankle sprain. And then how do you treat it? What do you do with this? What do you do with a Weber B? How do I put this? What's a high ankle? How long do you need to rehab it? When do you throw them in? These are all in your mental checklist, even if you're only seeing them once.
Another question from the Q&A, and I don't know, maybe Jace is the best to speak to this. But in terms of self-referral and Stark Law and seeing patients in the ED and then seeing them again in follow-up, how have you dealt with that? Is that something you've dealt with? What are the actual rules?
So, there's no rule against self-referral from that regard, it's more of a political question. So if you're working in the ER and then you're sending patients to yourself, you are going to have every orthopedic surgeon on the planet wanting your head. So you know, because they take call for a reason, and they're taking call because they have to take the good with the bad, right? So if all they get is the unfunded hip fracture and they don't get the Blue Cross that has a meniscal tear, they're going to know about it and get mad. If you are able, let's say you are able to refer into yourself, you have a follow-up clinic, you have to bill the patient in your clinic as a 1314. You cannot bill them as a 0 like it's a new patient. Now, there are different tax IDs, but the prudent thing to do so you don't run into problems is if you see them in your own clinic, bill them as if they're a follow-up patient and not a new patient. The biggest problem, though, once again, just like everything else, how many times in the ER have you heard, you stole this patient and gave it to your buddy? Well, we got other things to do with our time than, you know, steal stuff. But that's going to be the biggest consideration in referring into yourself. But it's certainly not illegal.
Sorry, Natasha.
No, so I definitely think it's really dependent on where you're practicing, right? In a place like where I am in New York, there's just a million patients, and no one's trying to track down those patients. So I think if you're in a more suburban or rural area where, you know, every patient referral really, really counts, you probably have to heed to distributing the load equally and appropriately. In New York, I just never referred to myself. I would always encourage my counterparts in the ER to refer to me, and that was plenty. So I don't think I didn't ever want to cross that boundary. So I think you just have to look at self-promotion in a way that it's appropriate. You know how to handle a lot of these conditions, and if you tell all of your, you know, co-faculty, they're most likely going to refer to you for the non-surgical things over others, and that way you don't have to kind of put your hat in the water with the patient that you're directly treating in the ER and avoid any of that political strife.
Another bonus there is if you can make friends with your local urgent cares, right? I mean, again, in our case, we've got like the giant network that Liz talked about earlier. But honestly, the few that are closest to my offices are not our MedStar urgent cares. And so if you go in and drop a handful of business cards, make sure the APPs and the physicians there have your phone number. You're happy to talk to them if they have a question that comes up during a shift. You're happy to see their people and follow up. Make it easy for patients to schedule with you. There are lots of ways to do that. I mean, again, like our urgent cares can schedule a follow-up from urgent care, right? So like the front desk can schedule them their follow-up. Jace said, put the net down, right? Once they come in, don't ever let them leave, right? So do that with your urgent cares. Make sure that they know you'll see whether it's the orthopedic care, whether it's the concussion, whatever it is. And again, like work with your orthopedist, right? We have a number where we can refer to our sports medicine group, which gets them ortho or primary care sports medicine first available, right? And so if I'm the first available, they see me. And that doesn't matter if that's a fracture or an ACL tear or whatever, they get me first because I'm open first, and we're pretty good at that.
What Kori said is good, which is, you know, if you're working an ugly shift and somebody sends you a pizza, that goes a long way, right? And you remember it. Well, you can do the reverse for an urgent care. Send them a pizza. Let them know who you are. Be available. I mean, they're doing the same thing you are. We're looking for path of least resistance to do disposition. So are they. So become a very easy path of least resistance and let them know you're there. And, you know, it's not that people have a price. It's how low a price it can be. I mean, people come in and give you a pen and people like it, right? So, you know, send them some food. And then the objective is they're who they think of when they need to dispo that patient out of there.
And not for nothing from a payer mix standpoint, which I'm lucky I don't think about a huge amount in our giant corporate system, but because urgent cares aren't held to the same EMTALA standard as emergency departments, right? They kind of pass the I can pay for urgent care. means they can also pay for their follow-up appointment, right? So that's actually not that's not a sucky group to start with.
No.
Whereas the emergency department patients are going to be a little bit harder in terms of managed care, in terms of Medicare, Medicaid, in terms of uninsured. The urgent care group is kind of a pre-vetted group from a payer mix standpoint.
Very true.
For those of you who are still doing emergency medicine, how do you switch off your sports medicine brain from your emergency medicine brain in the emergency department? Meaning, i.e., you know that this patient probably could benefit from a steroid injection. I mean, my ER department has Kenalog, but I choose not to do it in the emergency department. So how do you turn off your brain, or a shoulder, for instance, or how do you turn off that side of your brain when you're working clinically in the emergency room?
I can tell you, I wouldn't say I necessarily turn off my brain. I just turn off, what treatment option. Like, I'm still thinking about you're right. Like a shoulder, a supraspinatus tear. Like, no, like I'm not gonna start talking about all the different treatments and options and all this stuff in the emergency department. But I still do maybe not the full shoulder exam I do in sports clinic, but a modified version of it. So I wouldn't. I wouldn't use the term turn off the brain, because I don't necessarily do that. I just don't go into the same detail of treatment options and things like that. I just refer, and kind of going off everyone. I also, even though I've spoken to a fancy medical lawyer who told me it'd be completely fine for me to refer to myself, it's not a violation of Stark law. It's just not worth it to me. So it's not worth that stress in the back of my head of, is this really okay? So I also don't do that. But yeah, that's how I would turn off my brain. I would just not go into the same detail, I would say.
Yeah, going along with that, I think I don't turn it off. I just become more focused in my exam or my plan with the patient. And a lot of times for me, I put a referral where I'm at my system, and they will end up on my schedule the following week, just because I am one that has, slots open for urgent visits, and that's just how it works. So, a lot of times I can tell them, you actually, like, we have a pretty good referral system. So, you might get a phone call later today, and, it might be with me, it might be with another person. I think you could really benefit from a hip injection or a knee injection. And, I think a lot of what is so great about doing a fellowship in sports medicine and still working in the ER is being able to, counsel the patients appropriately. And I think that really helps them with, managing their issue at home. Because I think that's one of the reasons why patients then end up like maybe coming back for a repeat visit is, maybe if we take a little bit of extra time, or we have that knowledge to take a little bit of extra time to explain what's going on with them, I think that can be really helpful. Just knowing what the next steps are for them is super helpful.
Yeah, I definitely agree with that. And I will say I have a whole concussion speech for ER patients that, on the one hand, I always dread giving, because it means I'm going to spend 10 to 15 minutes talking to a patient instead of 30 to 45 seconds. But, I think it is very helpful for patients, and it helps them a lot with follow-up. One other question I wanted to pose to the group, especially for people who do non-clinical work that they are not reimbursed for, whether that's team coverage, education, anything else like that. How important has that been to your career, and how do you get involved with it? How did you get involved with it, and how would you advise people to get involved with something like team coverage if they're not now?
All right, I'm going to reject the premise of your question, and I'm going to be say here and say, don't do work that you're not compensated for, right? Unless you're very, very early in trying to get your foot in the
Except this.
and don't do it very long, right? Yeah. Like, sometimes you've got to volunteer for that race to make the contacts, right? But when you're doing work, right, the team coverage should come with something. It either needs to come through your institution with some sort of buy down of clinical hours, or you're doing it because you get something from it. If it is not building your practice or paying you money, I say this as somebody who's now getting a little bitter in my older age, but it's not worth your time. Like, your time is valuable, and I'm going to be kind of a hard ass here and say the more of you who do this for free, the harder it is for the rest of us to get paid, right? And so like we should value our time, and we should make it clear that like we're important, right? We're not going to pick up that extra ER shift without getting paid for it. So why would I cover a team that's going to call me 24 hours a day and have 88 games a year and not get paid for it? Right. I mean, I think
100% agree.
As a long-standing guy in this area, yeah, I 100% agree. Try to get a lawyer to work for nothing. Try to get an MBA to do the marketing for you for nothing. And we give away our services like it's a privilege. So one of the things when I was the CMO of the NBA is all the guys, and a lot of you guys are working for the NBA now, right? So you got paid, and I made this pitch. You get paid. These are professionals that are giving up their time, and there's an opportunity cost question on what they could be making working in the ER. And you ain't saving the universe by playing a basketball game in Dubai. So you have to get paid. Kori's hit it 100%. If the people who are giving away for nothing are diminishing our ability to leverage, and no lawyer would ever do that in their lives, right? So
tried to kind of, I don't want to say standardize this, but like even in the NHL, our group of airway physicians has tried to have some kind of back channel discussions about how much everybody's getting paid. We were actually warned that that might come dangerously close to collective bargaining, or we can't do a formal survey on that. But know that varies really widely, right? There are some places that are getting $600 a game to cover an NHL game, and there are some groups that are getting like 2 tickets and free concessions, right? And that's not the same. And I think that when we think about the number of nights and weekends, again, as somebody who split met for a long time, still doing ER, and I was an ER nocturnist for a while I was trying to do 50-50, right? The number of nights and weekends you spend on work only goes up when you do sports, because if you hadn't figured it out yet, sports also happens on nights and weekends and around holidays, right? Because that's when people go to basketball games and hockey games. And so those are just more nights and weekends you're going to spend. And if you start doing administrative stuff, Ben, to your point about teaching and lecturing and being part of the fellowship, I'll say ACGME has backed us up here by saying if you're an ACGME fellowship director, that has to be 20% protected time. If you're core faculty, that's going to start coming with some protected time in EM programs. And that's for the same reason, because it's just more time. Your days fill up with administrative work, and then your nights fill up with ER shifts and basketball games, and there's no time left.
I will say though, as a fellowship program director, that I like trying to get people to do things for free. It helps, especially when your institution won't give you extra money. So I like trying to get people to do things for free. But I agree 100%. I've heard Kori talk about this at the national level from AMSSM and at ASEP and at the PHATS convention. And I've heard her talk about this multiple times, and having a realm, and it all starts with us, right? It all starts with us as the physicians, whether it's us as EM or FM or orthos. We all should know our worth, right? And we know, I mean, if these professional teams can pay millions of dollars to the players, right? They can give us a little bit of money to just make us happy, right? So knowing what we're worth and sticking to that, I think is so important. So yeah, I agree with Kori.
So my number one advice,
Alex, when your fellows come down, I'll send you a bill.
Oh, they're coming in March. They're on this call right now.
Just expect a bill in April.
Okay. Go ahead, send it.
The check is in the mail.
So what I always remind my fellows when they're applying for jobs is everything needs to be accounted for in terms of what your expectations are. If you are an academic, faculty member, there's going to be expectation of teaching and research and things like that. But you have to have clarity on how much of that will have some RVU compensation or protected time. And learn from my mistakes. My first job, I was just happy to be there. I was happy to be the team physician for Columbia, and that's 700 athletes, and it was just me and one other doc, and that was 24/7 care in addition to my full-time clinical practice and ER shift. So I always felt like I had a job and a half, and I was getting paid for one. And it took a few years of me negotiating and renegotiating that to got a small stipend for that time, which it rose over the years. But because of my error, because I was the first primary care sports medicine person hired in that department, everyone after me that became a team physician, they're like, oh, you have to wait 3 years to be compensated because I had done it for free for 3 years. So hopefully they've corrected that since, and now they've grown. But that is it is definitely something, in fellowship and residency, you're just taught to be there for the experience, to give your time and learn. And it's important. In your fellowship, you should cover as much as you can cover and learn as much as you can learn. But when it becomes your job that your dependents, your kids are going to be living off of, and you're growing, and it's setting a precedent for your future career, you want to really know what's in your contract and make sure you get paid for it.
I want to give a business perspective here. You're not paid what you're worth. You're paid what you negotiate. So you can't be afraid to negotiate for what you want. And it's not an insult to a business person. They do this all the time. We're like, oh, please don't let me bother you. They have no problem going head to head and discussing and negotiating, right? And worst case scenario is you walk away, right? The reason I was the senior vice president of the NBA had not so much to do with my line of responsibility, but my pay, right? So for me to get paid like I wanted to get paid as a physician, they have pay scales, and I wanted that pay scale. So that makes me a senior VP. And, it's difficult to ask for stuff because it feels like they're doing us a favor. We're doing them a favor, right? I mean, it's an opportunity cost question. You could be in clinic making money. You're giving up your time and your effort, and you should be compensated for it. And you have to remember, in any negotiation, you have to be willing to walk away. And this is a big deal when it comes to wanting to do sports because it's shiny and people like it. And, you get to hang out with athletes, but that's not the job, really. The job is doing non-operative ortho and taking care of patients. And if you can integrate that, it's great, right? So, but yeah, we should not sell ourselves short, ever. We are highly skilled and paid professionals, and we should be treated like it.
All right. Well, speaking of needing to walk away, I know a few of our panelists have things that they have to get to. So if you guys need to step away, you can. We do have a little bit of a break scheduled in now. So if anyone wants to stick around and continue talking, that's totally fine. Any final thoughts, any final advice? Otherwise, we'll transition into a break and come back in about 10 minutes.